everybody. Thank you for joining us this afternoon for our second Tuesdays at 2. We had a great response from our first session a week ago, and very happy to gather everybody together again this afternoon. Just some housekeeping things before we get into conversation we'd like to have. If you're joining us via computer or phone, please make sure to mute your microphone. And if you have any questions at any time, please feel free to email us at community@dentalcommunity.ca, or else you can use the chat feature on this call today. We are not answering any questions in real time for obvious reasons. There's a large group of people, but we will continue to address those questions, which I'll talk about in a moment. Can you go to the next slide, please? Just want to thank a whole group of people who have we've been working with at the Dental Community Resource, consulting with this past week, members of our team, as well as many others who some of you have been in touch with over the phone, whose pictures do not appear in this composite here, but I assure you there's a group of people who are working tirelessly to try to make sense of the information as it emerges and to help guide us in some of the decision-making that we're all being forced to make. Next slide, please. Last week, we had several of you submit questions, specific, very detail-oriented, as is typically the case with dentists, questions regarding specific direction you were seeking as far as patient care is concerned. Obviously, we are not experts in that field, but we have members of our team who are, and we've submitted those questions for review. And our goal would be to present them to you on our site, on our Dental Community Resource site, once that information is available. Dr. Kevin Katz and Maya, who focus on infection control with us, have been overwhelmed, as you can imagine, these last 2 weeks. And so we're just obviously giving them all the space and time they require to be able to get back to us with those answers. So we haven't forgotten you and urge you for any questions that come up out of today's call and other concerns that you may have moving forward to please submit them either via the chats, which we're collecting those questions, or via the email. Next slide, please. So we are here today to continue a conversation, the discussion we had a week ago. But obviously, things have changed once again as they are evolving on a daily basis quite dramatically with the 6 p.m. email we all received yesterday afternoon. We're here to talk a little bit about the extended restrictions and the effect this may have on patient care, because we, as I'm sure you have, been thinking about strategies moving forward as to how we're going to take care of our emergency care patients, because obviously now the timeline that we originally had, which was March 15th, was the announcement, with communication to be received before the beginning of April. Well, we've had that communication yesterday, and now we're looking at a different perspective as far as time. Next slide, please. So this is what I'm referring to. We all received this email yesterday in the evening, where the college will not have information on when the clinics should reopen until the state of emergency has been lifted. And this is obviously, they're in daily contact with the Ministry of Health. So now any thought of us considering being back in our practices is directly tied to the Government of Ontario's future decision to lift the state of emergency at the earliest. The Royal College proceeded to say that there is no indication that this will happen soon. And they also went as far as saying that at this time, it appears very unlikely there'll be any lessening of restrictions in the month of April, which all of us, I'm sure, suspected. But if you, like Steve and I, and all of us, I'm sure, felt once we saw this in writing, it just made this real very fast. The reality is really set in. Our mindset when we last spoke was a matter of maybe a couple of weeks. Now we're looking at potentially a 7-week hiatus and possibly even more. Next slide, please.
When I was looking at the month of April and looking back from March 15th, which seems like, I don't know about the rest of you, but for me seems like an eternity ago. I can't believe it's only 2 weeks or a little bit more than 2 weeks. It seems like another lifetime. But I was thinking, maybe we're going to come on, I was not naive enough to believe that we were going to come back to work any of these days, and I thought maybe even the week after. But as we're watching the pandemic unfold around us, it became clear that the rest of this month was going to be a challenge. And when you really stop and think about it, and even reading in the most optimistic eyes, the memo we received yesterday, I think it's realistic that this month might be a question mark as well. And it now, for obviously for all of us, we're thinking financially and with our staff and so many stresses about having a closed clinic. But our role in patient care and what John and I want to really focus on as much as we can is patient care. How does this affect our decision making? What does this all mean? A short-term hiatus, which was what we were told on, and again, when I'm saying this, I'm just recapping the facts. I'm not certainly blaming everybody or anybody at all, or we're all in the same situation. Our regulators and the public health, and everybody's in the same scenario. We all want to open as quick as we can, but what I was planning for when my patients were calling me and I was having discussions with them was a short-term hiatus. Okay, I can't see you now. And really, we're telling patients we're going to see you in April. We moved our schedules from March 15th and maybe without giving it a lot of thought, kind of moved everything up into April, into the first week of April, without really, just because we didn't know what else to say, more than actual thought about would we be back. Because even then, there was no real indication that we would be. But now the reality of this short-term hiatus is now a long-term separation. And that's a different scenario. The patients I'm calling today, I'm not talking about, well, we'll push that off for a week or two. Now we're pushing it off for 6 or 7 weeks or 8 weeks by the time I can get to them at the very best scenario. It's one thing, and John, maybe you'll speak to this.
Yeah, so I think all of us are a bit comfortable with the notion in terms of preparing ourselves personally, our staff, our offices, when we block out time in the schedule for vacation, for holidays, that sort of thing. We know what it's like leading up to that time, and we know what it's like when we get back in the office and how we pay for it either way. And we can, if we're fortunate enough to get a couple of weeks off, successive weeks, 2 weeks usually is kind of the norm. For some people, maybe 3 weeks. And what that feels like. We all can relate what it feels like before we go away and when we come back. And typically this is something that's planned, unless, unfortunately, you've had to deal with an illness or a family emergency that's taken you away unexpectedly. What we're experiencing now is we've gone from the short-term hiatus now to a new reality where we're actually closed for a season. And this is unprecedented. I think it's a feeling we all think a little bit about how we prepare ourselves for these gaps in being in our offices. It's a new reality. It's uncharted territory for us, being closed for essentially an extended period of time like this. So there are lots of questions, clearly, lots of concerns. And our focus here, our area of major interest in this communication with you is how do we deal with this from a patient care standpoint, particularly from a patient emergency care standpoint, which is where we're at, because the anything that could be delayed for a few weeks or managed over the phone with medication suddenly could become a whole different problem as the weeks extend. Next slide, please. Go ahead, Steve.
I'm all of a sudden I was faced last night, and as we were preparing for our discussion today, we were fully intending to talk about how this has changed from a short hiatus to a long separation. I'm trying to always act, and as we're instructed to act, and as we are supposed to act in the best interests of our patients. But I'm faced that it's very difficult to know what the best interest is. I look at the benefit and the risk of not seeing our patients or seeing our emergency patients. And the benefit of seeing patients for emergency care is to reduce negative outcomes. And we're mandated to do that to a certain degree. But there's also risks associated with having a patient visit. And I understand strategies for medication and pushing things off for a couple of weeks are not the same strategies if we're talking about 6 or 8 weeks down the road. So determining best interest is really becoming more difficult, at least for me personally. It's a serious dilemma.
And we've had several discussions about this, right? I mean, if we go back to what we know or what we've been told on Friday, March 20th, the directive that we received on March 15th was expanded and very clearly stated that all non-essential and elective services should be ceased or reduced to minimal levels. And then there was this caveat, which, I understand the spirit of why it was written, but it poses some challenges for us right now. And we're very sympathetic to how, what a hopeless situation it is for our regulators as far as giving direction, because things are changing so rapidly. What we were told on March 20th was that allowable exceptions can be made for time-sensitive circumstances to avert or avoid negative patient outcomes, or to avert or avoid a situation that would have a direct impact on the safety of our patients. And this was seen through the lens of maybe a few weeks hiatus. Clearly this has changed. Now we're dealing with a much longer term, and the implications to care, to ongoing care, it becomes, I think, a lot more significant. And this is what we've been wrestling with, and we're certain that these are questions that you are entertaining too. Next slide, please. So the definition of an emergency care obviously is very clearly identified: orophacial trauma, significant infection, and prolonged bleeding or pain which cannot be managed by over-the-counter meds. And as Steve and I've mentioned, we know what that looks like. We can describe it, we can imagine it, and we've been able to get our head around it in these past 2 weeks. With the change now in the timeline, with now any hint of opening being tied to the lifting of the emergency status of the province, this now expands to a whole different level. Next slide, please. And now we're looking at this balance, right? We have been comfortable, we're trained, we're equipped physically, emotionally, intellectually to deal with morbidity as it relates to care. This is something that's, you gain lots of experience as the years go by, and we can manage that. We have protocols to manage that. For most of us, and I think it's safe to say, as dentists, we've never really had to entertain the idea of mortality as it relates to care. We've always left that to our physician colleagues. That's their world, the world they live in. We've dealt with complications, outcomes that we can manage, biologic ones, etc., but not with mortality. And this is, I think, the big change that is occurring as we look at the numbers of increased number of cases geographically in our province. As that's emerging on an hourly basis, we're having to consider things, take ourselves to a place where we've actually never been to before. And it's safe to say that unless you're working in a hospital environment, then maybe you have some familiarity, but the vast majority of us have never had to reconcile intervening care, dealing with emergency care and the potential risk to a patient's life. Next slide, please. So when it comes to morbidity, what are we talking about specifically? We're focusing, of course, there are always going to be ongoing concerns as far as patients will continue to have trauma, will continue to develop infections. Those things will continue to happen. What is happening as time is going by, and as this timeline now has expanded, we now have the issue of what happens to those patients who are mid-treatment? What happens to those patients who have ongoing prosthodontic restorative care? Folks that you place provisionals in their mouths the beginning of March, planning on completing their care the end of March, maybe the beginning of April. What about those folks who've had teeth extracted, immediate provisional, removable prosthesis inserted? These patients need to be followed up. I mean, that's typically our protocol. And yes, we could take care of them over the phone for a few weeks and maybe advise them on how to palliatively manage things. But as we're now looking at entering into the month of into the month of May, we have to have the conversation, or be aware of how are we going to take care of these patients. Steve, the presentation is off my screen.
Okay, let me go back and find it for you. It says I'm still sharing, so let me look for this. back up now, John?
Yeah, thank you. So we have these patients who are mid-treatment, who we had in good faith planned before. The sudden advice to close prevented us from seeing them on their routinely scheduled appointment. And we know that there are implications to delaying treatment for these patients. Do you want to comment on patients receiving implant care, Steve?
Yeah, I mean, we've had not having our routine follow-up appointments to evaluate integration of implants, long-term transitionals, the effect of leaving materials in place that weren't designed for that, the possibility of fracture in full arch cases where the entire integrity of that system, it depends on the implants being connected, rigidly connected, things that will ultimately end up being causing a long-term problem from this lack of care that we really didn't plan for in the middle of March.
Correct. And so by this long-term separation, obviously, the concern is that the fact that we cannot do our appropriate and time-proven follow-ups is going to have, without a doubt, it's going to adversely impact patient outcomes. To the extent that now suddenly there may be the costs that come up, those biologic costs in terms of changes to soft tissues as things are healing, recurrence of caries for some patients, and implicit financial costs that may change the originally prescribed treatment plans are going to be something we have to start thinking about when we get to go back and treat these patients, understanding now that there's this extension, this prolonged separation. We need to start preparing ourselves, I think, and Steve and I have been talking about this, as I'm sure you have in your minds, itching to get back to work, lots of reminders of the need for us to have to do that, but also kind of mentally preparing ourselves. So what is this care going to look like for these folks? And there are financial costs associated with that too, if additional, care is now suddenly warranted because of this prolonged separation. Next slide, please.
And you're going to get, John, if I can add, you're going to get into situations where, without doubt, there's going to be adverse outcome. And many of you have always heard me, I talk about when there's two people in the room, me and my patient, and there's an adverse outcome, one of the two of us is going to pay for it. And here it's of absolutely no fault of theirs and absolutely of no fault of ours as a caregiver. Yet somebody is still going to have to take that financial burden of these adverse outcomes. It's just another reality piled on top of so many that we have to deal with that I just wanted to bring to everyone's attention.
So this issue of mortality is now obviously a real concern, a real and very serious concern that we all have to entertain. Once again, a foreign territory for us. We're not usually equipped even to have manage the language of how do we talk to patients about mortality, because what we're referring to here is the risk of bringing a patient in who has a genuine dental emergency and somehow them becoming exposed to the virus, or us becoming exposed to the virus by virtue of seeing them. And this is something that, I know all of us are wrestling with. Mortality, once again, is not something that we've ever had to consider before. This is truly uncharted territory for all dentists. Next slide. And if we look at the distribution, the age distribution of COVID cases up until yesterday morning in Canada, we can see that the bulk, the COVID is indeed affecting our patient family, right? This to a large extent, whether you treat primarily a geriatric patient population, middle-aged patients, this is where the need's going to come from. So, if you live in areas where you take care of snowbirds who have returned or are returning, I think most of them have returned, now coming out of their 2 weeks, soon coming out of their 2-week quarantine period, they're going to need to see us for dental emergencies, and they potentially are also going to be vulnerable because they often come, as we know, with additional comorbidities. And so this problem starts to hit home really quickly and quite profoundly. Next slide, please. And if we just look at the confirmed cases in Ontario and projecting forward, looking at the data coming out of Asia, out of Italy, Spain, we have a sense of where this graph is going. And clearly today, March 31st, we are still entering into that high point. So that kind of gives us a sense. And I'm not saying this obviously to be dramatic in any way. We're just looking at some real information that impacts us, our loved ones, and who and how we're going to be able to take care of these patients. Next slide, please. So where are we at? I think it's official in all of our minds, although we've sensed it, we have it now in writing that we're dealing with a long-term separation. And we have to start equipping ourselves. And, the goal of these calls are not necessarily to provide solutions, because obviously we don't pretend to have solutions, but just to share with everybody and to highlight what everybody's thinking and to get us in the right headspace and mindset, because of course there's going to be a time where we're going to be getting back to work. And I think the more we think about this, we do have the time to do that, the better prepared we're going to be. It's critical, it's quite evident by the public health departments that emergency treatment should continue, and we need to avoid patients going to the hospital. I think it's anything we can do as oral healthcare providers, as members of a healthcare team. This is our area of expertise. We really do not want patients to end up on the doorstep of emergency rooms where they're battling far greater concerns, and that's obviously a serious concern. As we discussed last week, the way we've looked at this and becoming more and more comfortable with the idea is that we're assuming that we have to take the same thinking, same strategy of universal precautions as far as how we manage these patients, assuming everybody has it, because we know there are lots of patients who are asymptomatic who indeed may be carriers. Last week we talked about the N95 mask, and Steve, you want to comment on what we've done in this past week?
Yeah, a week ago Monday, we were given the update from the Royal College telling us that to see patients in certain situations, we were going to need fitted masks. And at that time, I don't know about the rest of you, many of us were taken by surprise for that. We promised last week that we would try to find a solution for that. We found a provider that was willing to come to our facility, and we opened it up to all of you. I have a picture of it, I think. There we are. That's testing. We tried to have an incredible amount of distance between us and bring people into the building just a few at a time. And it was quite a organizational feat, but we managed to get about 50 through of our colleagues. For those of you who weren't contacted yet, we haven't forgotten anybody. We're going through the list as they came in. I think this provider's agreed to come and do another day. Is it Thursday? Thursday, and if that fills in, he will promise to do another day again. We're being very diligent about only coming into the building one at a time, having a lot of social distance, doing everything we can to, again, decrease the risk of having any exposure. And we're quite comfortable with the protocols, but they are cumbersome. So be patient with us. We're doing our best. There's overall, I think it was well done yesterday. We had good reaction from almost everybody who attended. So yes, if you're interested in this, John, do you know where they can get more information regarding it?
It's posted on our site. We'll get to that at the end, Steve. Okay. But there's information available on the site.
And so that's going to continue on. My message here is my understanding is that's going to continue on. We're going to provide it as long as we can, or as long as there's a need for it.
Today, before we got on this call at 11:35, we got another email from the Royal College asking us to take a look at our stock of personal protective equipment to support the provincial response of the outbreak. The Ontario Health is urgently collecting data on PPE inventories across the health sector. There's a survey we're being asked to fill out. Next slide, please. And there's a downloadable PDF, 12 pages long, to help you fill that out. We just received this before we came on air. I haven't had a chance to look at the details, but what this is telling us, obviously, is the concern we're hearing in the media that one of the limiting factors here in the hospitals is that they're running out of equipment. You hear all kinds of stories of limitations for the physicians, nursing staff, all the team working in different hospitals having limited supplies. So clearly, I think it's incumbent on us as dentists to do everything we can to help support this very important and serious effort. Next slide, please. The other issue, I think on Saturday, we received an email for those of you who have ventilators or access to any of that equipment. The Ministry of Health is also taking stock, creating a list of what's available, because the fear, the concern, looking at what happened in other parts of the world, is that there's going to be a shortage. And if there's in any way we can contribute to that, I know, Steve, you have signed yourself up to make your equipment available, and others have too. And kudos to you for doing that, because obviously there's a significant need for that. And one other thing that I think we need to recognize in terms of where we're at today, March 31st at 2:27, is that our ability to get back into practice is tied to the lifting of the state of emergency by the government of Ontario. And that's something that we're all going to be obviously looking for. Not that it means that once that happens, we're ready to be back in practice, but that's what the RCDSO is going to be looking for in terms of guidance. We have at least a sense of what we're being tied to. Steve?
For us on March 31st, 2020, with this new reality, it brings me back to what's in the best interest of our patient. We talked today a considerable amount about the benefit and the risk of seeing emergency patients in our facility. And all I can really think of is, can I evaluate this? Can I create an environment? Can I set up protocols within our clinic and protocols that I want to share with all of you that can do our best to keep the staff that we work with, the patients that we see, ourselves, everybody, can we lower that risk? Use as little PPE as possible, but lower that risk. And so we're working to develop protocols. We're getting advice from infection control, our group, and people associated with us, and from public health, and trying to come up with reasonably valuable protocols to keep everybody safe. And as soon as we have them, we're working on them now. As soon as we have them, we will be happy to share. In fact, we will share share you all that document if you'd like to see it. And John, we will be able to put it on our website as well.
Yeah, if you just go to the next.
For that, because if that's the case, we need to be developing best practices for emergency care during this pandemic, and protocols to protect patients, clinicians, and the entire team. So we're trying to create a document that will be just, you're welcome to use and change and do whatever you'd like to, just to try to help us get some best practices into keeping everybody safe.
And this information, so first of all, a couple of things before we close. We're getting close to our to 2:30. We'll look forward to another Tuesdays at 2 on April 7th. You'll receive the information to connect with us. And if you go to the next slide, Steve, we've continued to update our site with the most current news and updates, as well as any information, like Steve said, that we're happy to share with you. We're starting to organize this page a little better by having differentiating between RCDSO posts, public health posts, information from the ODA, Government of Canada, and then some issues specifically related to patient care. Please reach out to us using the community@dentalcommunity email address, and we look forward to getting together again in a week in this manner. But as information emerges, we will be sure to post it and communicate with you via this website. Thank you. Be well and stay safe. Thank you.
Thank you, everybody.